In this module, we are going to discuss about the pulmonary venous abnormalities and echocardiographic identification of all those individual abnormalities. The pulmonary venous abnormalities can be total or partial anomalous pulmonary venous drainage, total or partial cardiac atrium, and pulmonary vein stenosis or pulmonary vein atresia. Total anomalous pulmonary venous connection is one of the commonest pulmonary vein abnormalities seen in clinical practice. They are broadly classified into supracardiac Ta Pvcs, intracardiac and infracardiac Ta Pvcs. Some of them may be associated with obstruction to the pulmonary venous pathway. A majority of them will be having associated pulmonary hypertension. Some forms of Ta Pvc can be associated with other congenital heart diseases, especially in situations like heterotaxy. Before we go into the pulmonary venous abnormalities, it is very important to recognize how a normal pulmonary vein drainage will look on the echocardiography. The pulmonary veins are best seen in parasternal short axis view behind the aortic root as they enter into the left atrium, and they may also be seen in the suprasternal view on a little bit posterior sweep. This view is sometimes called as a crab view. The body of the left atrium forms the body of the crab, and the pulmonary veins are represented as the legs of the crab. Right upper pulmonary vein is best visualized in subxiphoid short axis view. After we visualize the superior vena cava entering into the right atrium, a rightward sweep of the probe in subxiphoid short axis view is going to show the right upper pulmonary vein entering into the left atrium. This right upper pulmonary vein will be seen anatomically to enter the left atrium between the superior vena cava anteriorly and the right pulmonary artery that is seen as a rounded shadow posteriorly. When we get the color Doppler that confirms the flow of blood from the right upper pulmonary vein into the left atrium, behind the superior vena cava and anterior to the right pulmonary artery. On the parasternal short axis view, behind the aortic root, we see the left atrium, and on the left side of the left atrium, we see the two pulmonary veins entering. The left upper pulmonary vein has a blue coding and the left lower pulmonary vein has a red coding. Similarly, the right pulmonary veins will be seen on the right side of the left atrium with the same color coding. The upper pulmonary veins take a blue color and the lower pulmonary veins take a red color. Suprasternal view is another useful view for demonstrating the pulmonary veins. Here we see on the left side of the screen the two pulmonary veins entering into the body of the left atrium. As I told you earlier, this is also called as the crab view. In this crab view, you can see the left upper and lower pulmonary veins entering into the left atrium on the left side and the right upper and lower pulmonary vein entering into the left atrium on the right side. In every echocardiogram done on evaluation of a congenital heart disease, it is extremely important to document a normal drainage of all the pulmonary veins on both sides. It's important to recognize why the upper pulmonary vein take the blue color and the lower pulmonary vein take the red color on both the parasternal short axis and suprasternal views. This is a volume rendered CT pulmonary angiogram viewed from behind. You can see the upper and the lower pulmonary veins on both the sides entering into the left atrium. In most of the hearts, there are two veins on the right side and two veins on the left side. In some, the two veins may combine together to form a common vein, and in some of the hearts, there can be three veins also. on each side. When we look at the lung anatomy, we know that the upper pulmonary vein drains the lungs above the major fissure and the lower pulmonary vein drains the lung below the major fissure. In the right side, the upper and middle lobe of the lung are anterior and superior to the major fissure, and the lower lobe is posterior and inferior to the major fissure. The right upper pulmonary vein drains the upper and the middle lobe, which are located anteriorly and superiorly. So the veins course in the opposite direction towards the left atrium. So they course posteriorly and inferiorly from their origin towards the heart. In both the suprasternal view and the parasternal short axis view, therefore the upper pulmonary vein takes a blue color because the flow is from anterior to posterior and superior to inferior. When we look at the lower pulmonary vein drains the lower lobe, which is located inferior and posterior to the major fissure, and so the course of the pulmonary vein is in the opposite direction. The blood flows anteriorly and superiorly, and hence it takes a red color on the echocardiogram in both the parasternal short axis view and suprasternal view. On the left lung, the upper lobe that includes the lingular lobe is anterior and superior to the major fissure. The entire lower lobe is posterior and inferior to the major fissure. As we described on the right side, in the left lung also, the left upper pulmonary vein that drains the upper and the lingular lobe courses posteriorly and inferiorly towards the left atrium. And so the color flow in the left upper pulmonary vein takes a blue color. The lower pulmonary vein drains the lower lobe and the vein courses superiorly and anteriorly towards the left atrium. So it takes a red color. This is a normal parasternal short axis view that shows all the four pulmonary veins that drain back into the left atrium behind the aortic root. This concept in anatomy gets reinforced when we see this axial slice of a CT scan that shows the upper and the lower pulmonary veins on both sides. We can see that the upper pulmonary veins drain from front to back and the lower pulmonary veins drain from back to front. With this introduction about how to visualize a normal pulmonary vein, let us move on to the various pulmonary venous abnormalities that we see in clinical practice. The commonest type of Ta Pvcs are the supracardiac types of Ta Pvc. It may drain into the left vertical vein towards the left innominate vein, a right vertical vein to the right superior vena cava. It may enter the right azygos vein, or sometimes form a left vertical vein that drains into a left superior vena cava, which then drains back into the heart through the coronary sinus. Coming to intracardiac drainage, it can either enter the coronary sinus or directly onto the posterior wall of the right atrium. The third type is called as the infracardiac or infradiaphragmatic type of Ta Pvc. We are going to demonstrate all the different types of Ta Pvcs with various illustrative examples. We will start with a supracardiac Ta Pvc unobstructed that drains through the left vertical vein. This diagnosis is best made on the parasternal short axis view. A cartoon illustration of the commonest type of supracardiac Ta Pvc, where the confluence of the pulmonary vein, also called as the common chamber, drains through a left vertical vein that courses anterior to the left pulmonary artery and drains into the left innominate vein. This parasternal short axis view shows all the four pulmonary veins entering into the confluence or the common chamber and then ascending up on the right side of the screen as the left vertical vein. The way to differentiate between the right pulmonary veins and the left pulmonary veins on this short axis view is to identify the aorta, the descending thoracic aorta. If you carefully look posterior to the pulmonary veins, there is a blue systolic flashing of blood flow in the descending thoracic aorta. All the left pulmonary veins come from left side of the mediastinum, and so they will be seen on left side of the aorta, whereas the right pulmonary vein will be seen entering from the right side of the descending thoracic aorta. In almost all patients with supracardiac Ta Pvc of this type, you can see the left upper pulmonary vein draining as the last venous channel almost into the left vertical vein itself. Once again, notice that the descending thoracic aorta is seen as a blue systolic flashing round dot, and we need to identify that very clearly. The veins that drain on the left side of this descending thoracic aorta represent the left pulmonary vein, and the veins that drain to the right of this descending thoracic aorta refer to the right pulmonary veins. Suprasternal view is yet another very useful view in visualization of these types of supracardiac Ta Pvcs. The ascending left vertical vein shows uniform laminar red flows that indicate that the left vertical vein is not obstructed at all. Sometimes there can be obstruction in the place where the left vertical vein enters into the left innominate vein, or in the middle of the course of the left vertical vein. However, in this example, there is no obstruction. In this suprasternal view, all the four individual pulmonary veins are nicely traced. You can see that the right upper pulmonary vein, which is coursing from superior to inferior, is taking a blue hue. Both the lower pulmonary veins, the right and the left, are taking a red color. The descending thoracic aorta with the flashing blue colored systolic blood flow is seen between the right and the left pulmonary veins. As we described earlier, the left upper pulmonary vein is the last to drain into the left vertical vein, and so often it also takes a red color because the direction of flow is towards the left vertical vein. It is important to recognize that the left vertical vein often courses anterior to the left pulmonary artery, and so is not obstructed in its course. In this parasternal view, we can clearly appreciate the left vertical vein on the left side of the main pulmonary artery and anterior to the left pulmonary artery, and so not getting obstructed at all. If this left vertical vein is going to course posterior to the left pulmonary artery between the LPA and the left bronchus, it may get obstructed in the hemodynamic vise, which is also called as a bronchopulmonary vise. Let us see some types of left vertical vein obstruction. In this subxiphoid view, we see the right atrium, the inferior vena cava draining from below, the superior vena cava draining from above. The superior vena cava is grossly dilated, indicative of a supracardiac type of Ta Pvc. As we proceed with the subxiphoid short axis view, we identify that the right ventricle is grossly dilated, the interventricular septum is partially bowing into the left ventricle during systole, indicative of severe pulmonary arterial hypertension, and the likelihood of RV systolic pressure being higher than the LV systolic pressure. You can also notice that the right ventricular systolic contractility is low. The poor RV contractility and the elevated right ventricular systolic pressure is confirmed on this apical view, where the left ventricle is almost squeezed to one corner. When we interrogate the tricuspid regurgitation signal on this apical four-chamber view, we get a rough idea about the right ventricular systolic pressure, and we clearly know that this is suprasystemic. The RVSP is 109 added to right atrium. On the parasternal short axis view, we see the pulmonary venous confluence behind the aortic root. You can see all the pulmonary veins taking a red color and getting into the confluence. This common chamber is ascending up, and behind the left pulmonary artery you can see a mosaic pattern indicative of significant obstruction of the left vertical vein at the bronchopulmonary vise. This bronchopulmonary vise is formed by the left pulmonary artery anteriorly and the left bronchus posteriorly. On a cartoon example, the left vertical vein that is getting obstructed is exactly located posterior to the left pulmonary artery and anterior to the left bronchus. In situations of pulmonary hypertension where the pulmonary artery distends further and further, the level of obstruction caused by this bronchopulmonary vise is going to worsen more and more, and as time passes, the bronchopulmonary vise becomes more and more clinically significant. In the same patient from suprasternal view, we observe that there is a lot of turbulence in the distal portion of the left vertical vein due to the obstruction caused at the level of the bronchopulmonary vise. When we use Doppler to interrogate the gradients across this left vertical vein obstruction, we find that there is quite a substantial pulmonary venous gradient of around 20 millimeters of mercury. In the previous example, we saw a classical obstruction of the left vertical vein happening at the bronchopulmonary vise. Let us move on to other sites of obstruction in the supracardiac Ta Pvc. We start with a subxiphoid short axis view. We identify the dilated right superior vena cava, the accelerated flows in the right superior vena cava. But as you observe the superior vena cava right atrial junction, there is a flow acceleration that's happening, and anatomically you can see that there is a narrowing of the superior vena cava atrial junction. Dilated right superior vena cava in subxiphoid short axis view is the classical hallmark of all types of supracardiac Ta Pvcs. In this cartoon example, we show the level of obstruction. The confluence or the common chamber is draining into a left vertical vein that courses through the left innominate vein and enters the right superior vena cava. However, the place where the right superior vena cava is entering into the right atrium at the cavo-atrial junction, there is an anatomic narrowing. When we measure this cavo-atrial junction on subxiphoid short axis view, we find that the distal right superior vena cava is almost around 2 centimeters, whereas the cavo-atrial junction is only about 9 millimeters. This is a suprasternal view of the same patient. We identify that the right superior vena cava is grossly dilated, getting a blue color. However, at the superior vena cava right atrial junction, there is an obstruction and that is causing a mosaic appearance. While the superior vena cava above is well dilated, the cavo-atrial junction is significantly narrowed. This suprasternal view shows a significant turbulence in the cavo-atrial junction. The level of this obstruction in this patient is at the superior vena cava right atrial junction. So far, we have seen 3 different types of supracardiac Ta Pvc. The first was totally unobstructed, the second was obstructed at the bronchopulmonary vise, and the third was obstructed at the superior vena cava right atrial junction. Let us move on to more types. In this subxiphoid coronal view, we are able to appreciate a hugely dilated right superior vena cava, indicating that there is a supracardiac Ta Pvc. Compare the size of the right superior vena cava with the adjacent ascending aorta. Unlike the previous patient, here the right superior vena cava is not obstructed at all and is uniformly dilated till the cavo-atrial junction. When we look at the parasternal short axis view, we find the confluence of the common chamber posterior to the aorta and the main pulmonary artery, and it converges towards the left vertical vein. From the suprasternal view, we confirm that there is no obstruction of the left vertical vein and there is a large flow in the dilated left vertical vein. In this suprasternal view, with a broad color sector, we are able to clearly appreciate all the pulmonary veins converging to the common chamber, an unobstructed flow from the common chamber into the left vertical vein. There is no obstruction at the level of bronchopulmonary vise. The flow into the left innominate vein and subsequently into the right superior vena cava is looking laminar. When we look at the same heart from the apical view, we identify that the right ventricle and the right atrium is dilated. The right ventricular systolic contractility is low. If you carefully look at the intraatrial septum, we identify that the septum secundum is bulging towards the left atrium, indicative of very high right atrial pressures. Color flow across the dilated tricuspid annulus shows a large flow of blood from the right atrium into the right ventricle and a mild grade 2 tricuspid regurgitation. On a subxiphoid coronal view, we are able to see the bowing of the septum secundum in the region of fossa ovalis. We find that the foramen ovale is grossly inadequate in its size as shown by the arrow. If we have to draw a cartoon of this example, all the four pulmonary veins drain onto the common chamber and that ascends up as the left vertical vein. This is all colored in red. It then enters the left innominate vein and the right superior vena cava and enters into the right side of the heart. The systemic cardiac output has to be generated by the flow across the fossa ovalis, and here in this patient it is through a small patent foramen ovale, and that is the site of obstruction. With the color Doppler interrogation across the intraatrial septum, you can see significant turbulence that is happening in the blood flow from the right atrium into the left atrium. As the flow is from the right atrium into the left atrium, it is taking a blue color, but the mosaic pattern in the left atrium is indicative of significant obstruction at the level of fossa ovalis. When we look at the anatomic size of the intraatrial communication, it's just 4 millimeters. A 4 millimeter orifice is grossly inadequate to carry the entire systemic cardiac output. In the last example of supracardiac Ta Pvc that we saw, the level of obstruction is at the foramen ovale. The fossa ovalis communication was too small, and that was causing a significant obstruction of blood flow from the right atrium into the left atrium. Let us move on to more examples of supracardiac Ta Pvc. The next example is a baby who presented with severe hypoxia, pulmonary hypertension, and features of high pulmonary vascular resistance. In this parasternal short axis view, you find a long horizontal common chamber or the confluence of the pulmonary veins. The right pulmonary veins draining into the common chamber are shown by two arrows, one above and one below. Left lower pulmonary vein is shown by an arrow on the right side of the screen. You can observe that the descending thoracic aorta is shown in the middle. The right pulmonary vein and the left pulmonary vein drain into the common chamber on either sides of the descending thoracic aorta. The confluence of the pulmonary vein is nicely shown. Anatomically, we can see the right upper, the right lower and the left lower pulmonary vein entering into the confluence. If we carefully look at the pulmonary veins individually and the common chamber, We find in this instance that all the individual pulmonary veins and the common chamber are looking much smaller. Compare the size of the pulmonary veins and the common chamber with that of the anterior superior vena cava, the anteriorly located ascending aorta, and the anteriorly located main pulmonary artery. All the pulmonary veins and the common chamber are looking smaller. You also notice that unlike the previous instances, the color flow is not extremely brisk. This is indicative of relatively low pulmonary blood flow and low pulmonary venous return. From the suprasternal view, we observe the blood flows from the common chamber entering in the left vertical vein towards the left innominate vein. You notice that for getting the color flows in the pulmonary veins and common chamber, we had to reduce the color velocity scales to 46 centimeters per second, and that is the reason why the flows in the left vertical vein are looking with a mosaic pattern. In this frozen frame from the suprasternal view, we observe that the individual pulmonary veins are smaller. The common chamber is roughly the same size as the ascending aorta. The right superior vena cava is mildly dilated. Compared to most of the previous examples, in this patient, the pulmonary veins and the common chamber are significantly looking small. When we individually measure the pulmonary veins, the right upper pulmonary vein is measuring about 3 millimeters and the right lower pulmonary vein is measuring about 3.5 millimeters. When we measure the common chamber, it is also very small and measures only about 6.5 millimeters. So the entire pulmonary venous channels, the individual pulmonary veins and the common chamber all are uniformly small. On a cartoon example, we find that there is a diffuse pulmonary vein, common chamber, left vertical vein, hyperplasia. All the structures are uniformly smaller. There is no discrete level of obstruction, but the entire pulmonary venous communications are looking small. We can't pinpoint to any discrete area of obstruction. All the individual pulmonary veins are only about 3 to 4 millimeters. The common chamber and the left vertical vein is only about 6 millimeters. There is a diffuse hyperplasia of the pulmonary venous tree. Let us see yet another example of a small infant presenting with supracardiac Ta Pvc and severe pulmonary arterial hypertension. On the parasternal view, we start seeing the right pulmonary veins entering the confluence, and as the sweep is made more and more towards the left side, we appreciate the left upper and the left lower pulmonary veins also converging towards the confluence and going up in the left ascending vertical vein. From a suprasternal view, we identify that there is no obstruction to the left vertical vein. There is no obstruction in the innominate or superior vena cava. Contrary to the previous patient, there is no obstruction at the level of fossa ovalis in this patient. This subxiphoid view is showing a laminar flow from the right atrium into the left atrium, taking a blue color across the foramen vein. Subxiphoid short axis view shows that there is a grossly dilated right ventricle, poor right ventricular contractility, indicative of severe pulmonary arterial hypertension. As there is severe pulmonary arterial hypertension, the right ventricular systolic contractility is also significantly impaired. You can see the gross trabeculation of the right ventricle, the marked right ventricular hypertrophy that is noted. The reason for severe pulmonary arterial hypertension in this baby is due to persistence of high fetal pulmonary vascular resistance into the postnatal period. Many patients with supracardiac Ta Pvc who are having pulmonary arterial hypertension may not have any pulmonary venous obstruction at all, and This will be the persistence of the pulmonary hypertension seen in the fetal life going on to the postnatal period. In all these patients, we should try to look at all the possible contributors of pulmonary hypertension before deciding that it is persistence of the fetal pulmonary vascular resistance. Yet another example of supracardiac Ta Pvc, where the severe pulmonary hypertension is also contributed by a large perimembranous ventricular septal defect. Such association should be carefully looked for. The parasternal long axis view of this patient shows a VSD located below the aortic root and shunting from right ventricle into the left ventricle. To summarize, the common type of Ta Pvc is supracardiac, and the drainage is often into the left vertical vein and subsequently into the left innominate vein. The pulmonary arterial hypertension may be associated with obstruction in the pulmonary venous pathway, but sometimes even without any obstruction due to persistence of the fetal pulmonary vascular resistance. If there is an obstruction, it can be due to diffuse pulmonary vein or common chamber hypoplasia, a discrete obstruction in the left vertical vein, a constriction of the left vertical vein due to bronchopulmonary wise, obstructions at the right superior vena cava or cavo-atrial junction, or a restrictive patent foramen vein. If there are no observable reasons for pulmonary hypertension, we should look for alternative causes. There may be large ventricular septal defects or patent ductus arteriosus, which may cause the pulmonary arterial hypertension to be equal to the systemic pressure. Surgical correction of this form of supracardiac Ta Pvc involves anastomosis of the common chamber of the confluence on to the posterior wall of the left atrium, thereby giving an unobstructed flow from the common chamber directly onto the left atrium. In most of the patients, the anastomosis that is made between the common chamber and the left atrium will be wide open. However, if there is a cicatricial narrowing of the anastomosis due to progressive fibrosis around the anastomosis, there can be an anastomotic obstruction with a gradient that happens along the anastomotic level. This is an example of an anastomotic narrowing. This parasternal long axis view is showing the common chamber to LA anastomosis, which is having a significant obstruction and a mosaic flow that is seen into the left atrium. Apical fourth chamber view shows persistence of right ventricular hypertrophy. The right atrium and right ventricle are not dilated because there is no longer a shunt from the left to the right. When we interrogate the tricuspid regurgitation jet for assessing the right ventricular systolic pressure, we find that the pulmonary arterial hypertension is very severe. When the gradient across the anastomosis is recorded, we find that there is a mean pulmonary venous gradient of 19 millimeters of mercury, which is quite substantial. In apical fourth chamber view, here we see that there is a mosaic flow across the anastomosis from the common chamber into the left atrium, indicative of obstruction at the level of anastomosis. We can zoom into the region of the anastomosis to clearly understand the anatomy of the anastomotic site. This is the common chamber to left atrial anastomosis. On a parasternal long axis view, we clearly see the substantial obstruction from the pulmonary venous confluence into the left atrium. For echocardiographic assessment of the severity of pulmonary hypertension, we use the color flows across the tricuspid valve and the pulmonary valve. When we interrogate the tricuspid regurgitation gradient, the right ventricular systolic pressure is calculated by the TR's maximum velocity plus the right atrial pressure. When we interrogate the pulmonary regurgitation jet, the peak of the pulmonary regurgitation is going to give a rough indicator of the mean pulmonary artery pressures. This is a spectral Doppler of the pulmonary regurgitation jet. You can see that the peak of the pulmonary regurgitation jet is 54 millimeters of mercury, which is a rough correlate of the pulmonary arterial mean pressure. A magnified view of the anastomotic area shows that the anastomosis is measuring less than 5 millimeters. This is going to cause a significant obstruction to the pulmonary venous pathway because the whole of the pulmonary venous return has to enter into the left atrium through this less than 5 millimeter orifice. Let us move on to the other types of supracardiac Ta Pvc. The pulmonary veins can drain into a confluence that can either drain through a right vertical vein into the right superior vena cava. It can connect to the azygos vein and thereby subsequently draining into the right superior vena cava. Sometimes the confluence can form a left vertical vein that drains into the left superior vena cava, and in these patients, if the left superior vena cava is draining through the coronary sinus back into the right atrium, then that will be another source of a supracardiac Ta Pvc. This is a still frame from the subxiphoid short axis view. You find that there is a dilated right superior vena cava entering a dilated right atrium. The inferior vena cava is much smaller than the superior vena cava. Posterior to the RSVC, there is a large right vertical vein. This right vertical vein courses posterior to the right pulmonary artery, ascends up in the superior mediastinum, and then enters onto the posterior wall of the right superior vena cava. Color Doppler interrogation shows that there is a blue color on the right vertical vein because from subxiphoid view, the flow is from below upwards in the right vertical vein. Thereafter, it turns on into the posterior wall of the right superior vena cava, and the flow in the right superior vena cava is red because the flow is towards the transducer. When we run the movie of the subxiphoid view, we are clearly able to appreciate a large right vertical vein that courses posteriorly, ascends up in the superior mediastinum, enters the right superior vena cava on the posterior wall, and turns around back into the right atrium. So this is a right superior vena caval type of Ta Pvc through a right vertical vein. On a cartoon example, we find that all the four pulmonary veins form a confluence. There is a right vertical vein that drains this confluence. It ascends up and drains into the right superior vena cava. So this forms the right vertical vein. On a subxiphoid coronal plane sweep, we can clearly identify a formation of a confluence and the ascending right vertical vein taking a blue color because the flow is from below upwards. In this right vertical vein type of supracardiac Ta Pvc, very often the right vertical vein courses in the posterior right paravertebral gutter, much behind the right bronchus and the trachea, and is not getting obstructed at all. However, if the right vertical vein is coursing anterior to the right bronchus and trachea and posterior to the right pulmonary artery, it can get involved in a same bronchopulmonary vise similar to the left bronchopulmonary vise that we described earlier. This is an example of an obstructed right vertical vein. You see that the right vertical vein is anatomically quite narrowed behind the right pulmonary artery. The right superior vena cava is significantly dilated. In the right vertical vein type of supracardiac Ta Pvc, the right superior vena cava is invariably dilated. However, unlike the left vertical type of Ta Pvc, the left innominate vein is normal in size. Subxiphoid short axis view. A hugely dilated right superior vena cava is seen. The common chamber is draining through a right vertical vein. This right vertical vein is compressed by the right pulmonary artery anteriorly. You're able to see that the right vertical vein is anatomically much smaller. From a suprasternal view, we understand that the right vertical vein is draining in the middle of the right superior vena cava, roughly about 1.7 centimeter below its formation. The right vertical vein that is entering into the right superior vena cava is anatomically narrowed to a 7 millimeter channel. From the suprasternal view, this right vertical vein obstruction caused by the right bronchopulmonary vase is measured, and there is a mean gradient of 12 millimeters of mercury. Sometimes a Ta Pvc can directly enter into the right superior vena cava without forming a vertical vein. The confluence can directly drain into the right superior vena cava without an ascending vertical vein. This is a subxiphoid short axis view. We find that there is a common chamber. The confluence is draining directly onto the posterior wall of the right superior vena cava, immediately below the right pulmonary artery. There is no right vertical vein at all. On the parasternal short axis view, we find the left upper and the lower pulmonary vein converging towards the confluence. The flow in the left upper pulmonary vein is shown by blue, and the flow in the left lower pulmonary vein shown by red are pointed out with two arrows. The confluence courses towards the right superior vena cava and directly drains into the right superior vena cava. So far, we had seen three different examples of right superior vena caval type of Ta Pvcs. The first example was with formation of a right vertical vein without obstruction. The second example was formation of a right vertical vein which was getting obstructed at the bronchopulmonary vase. The third example was a direct drainage of the confluence to the right superior vena cava without an ascending vertical vein. Let us move on to another type of right superior vena caval Ta Pvc. Here the drainage is into the right azygos vein. On the subxiphoid short axis view that is shown in this picture, you can identify the azygos vein that is posterior to the right pulmonary artery, hooking all around the RPA and entering onto the posterior wall of the right superior vena cava. Color flows across this right azygos vein show that there is a marked turbulence of flow in this right azygos vein. You will know that the azygos in fetus is not a very big structure. So anatomically it remains very small. As soon as the baby is born and the pulmonary blood flow increases, the increasing pulmonary venous return that is flowing through the azygos vein will give an obligatory gradient. So there is always an obstruction in the azygos type of Ta Pvcs. From the suprasternal view, we can appreciate the drainage of the azygos vein into the right superior vena cava immediately above the right pulmonary artery. There is a marked turbulence indicative of obstruction at the level of azygos vein. If you draw a cartoon of this example, the pulmonary veins form a confluence. The common chamber connects to the azygos vein through a communicating vein, and the azygos subsequently enters into the right superior vena cava. Since the azygos is not a very huge structure, it always produces some obstruction to the flow of pulmonary venous blood. Most of the azygos type of Ta Pvcs are obstructed. A spectral Doppler interrogation of the anastomosis of the azygos into the right superior vena cava indicates that there is an obstruction of the right azygos vein. Unlike the right vertical vein type of Ta Pvc, here you find that the drainage into the right superior vena cava is immediately above the right hilum of the lung. The course of this azygos vein is immediately above the right pulmonary artery and the right bronchus. We move on to more unusual forms of supracardiac Ta Pvc. Pulmonary veins can drain into the common chamber. The common chamber can form a left vertical vein, and this left vertical vein may drain into the left superior vena cava. However, if there is a persistence of left superior vena cava through the coronary sinus into the right atrium, the flow of the blood will be from the left vertical vein into the left superior vena cava, and it will turn around inferiorly towards the coronary sinus. This parasternal short axis view shows the formation of the confluence. The common chamber drains into the left superior vena cava. The dilated structure seen on the right end of the screen is the dilated left superior vena cava. In this patient, there is a persistence of LSVC towards the coronary sinus into the right atrium. So from the suprasternal view, we find a blue color because the left jugular and the subclavian are converging to form the left superior vena cava, and that is coursing towards the coronary sinus. You can appreciate the left vertical vein that enters into the same left superior vena cava in its mid part. From the suprasternal view, we observe that the left superior vena cava is a little bit smaller above the drainage of the left vertical vein. However, it gets dilated after receiving the pulmonary venous channel. After receiving the pulmonary venous channel, the left superior vena cava becomes dilated and enters into the coronary sinus, and thereby entering into the right atrium. If we have to represent this on a cartoon, all the four pulmonary veins form the confluence. The common chamber forms a short left vertical vein. This left vertical vein enters into the left superior vena cava, and this persistent left superior vena cava subsequently drains through the coronary sinus into the right atrium. These are unusual forms of supracardiac Ta Pvc. On a subxiphoid short axis view, you can see the common chamber draining on to the left superior vena cava through a short left vertical vein. After the pulmonary veins enter into the left superior vena cava through the short left vertical vein, the pulmonary venous blood turns around in the left superior vena cava into the coronary sinus, thereby entering the right atrium. On a parasternal short axis sweep, we can identify the individual left upper and the left lower pulmonary vein entering into this confluence. After this detailed discussion on different types of supracardiac Ta Pvc, some of them through the left vertical vein, some of them through the right vertical vein, some through the azygos vein, some through the left vertical vein into a left superior vena cava, we move on to the cardiac type of Ta Pvc. Among the two cardiac types of Ta Pvc, the coronary sinus type of Ta Pvc is the most common. The right atrial Ta Pvc is less common and is often seen in the setting of right isomerism. Most cardiac Ta Pvcs are unobstructed. A subxiphoid coronal view showing the pulmonary veins draining on to a dilated coronary sinus. This is a classical view of a coronary sinus type of Ta Pvc. A color Doppler interrogation from the pulmonary vein into the coronary sinus shows that the pulmonary veins are converging towards the coronary sinus. Most of the coronary sinus Ta Pvcs are unobstructed. There will be a mild flow turbulence due to high pulmonary blood flows. You can see that the spectral Doppler tracing is showing a mean gradient of around 4 mm of mercury, which is not very significant on the pulmonary venous pathway. Most of the coronary sinus type of Ta Pvcs are best recognized from the subxiphoid coronal sweep. You appreciate on a posterior sweep that all the pulmonary veins drain into the dilated coronary sinus and enter the right atrium. If you sweep the transducer a little bit anteriorly, you can appreciate the foramen ovale and the flow of the blood from the right atrium into the left atrium, taking a blue color. On a parasternal long axis view, after you visualize the left ventricle, the aortic valve and the mitral valve, if you make a rightward sweep towards the tricuspid valve, you can appreciate the dilated coronary sinus in patients with coronary sinus type of Ta Pvc. The dilated coronary sinus will enter posterior to the tricuspid annular plane. A cartoon example of coronary sinus Ta Pvc. All the four pulmonary veins converge into the dilated coronary sinus and enter into the right atrium. The systemic cardiac output is maintained by the flow of the blood from the right atrium into the left atrium through the fossa ovalis ASD. In any Ta Pvc, it is very important to identify all the pulmonary veins entering into the confluence. In this parasternal short axis view of the coronary sinus Ta Pvc, we can identify the left upper, left lower, the right upper and the right lower pulmonary veins draining into the confluence. We need to confirm the pulmonary venous flows by color Doppler interrogation. The left upper and the left lower pulmonary vein are shown by the blue and red colors entering into the confluence. From the apical four-chamber view, the coronary sinus is a very posterior structure and so will be visualized only when we make a posterior sweep. In the normal four-chamber view, the mitral and the tricuspid valves are visualized, and here we will be able to appreciate only the right atrial and right ventricular dilatation. The coronary sinus will appear only when we go posterior to the mitral annular plane. In coronary sinus Ta Pvcs, from the subxiphoid view, we will be able to appreciate the adequacy of the fossa ovalis ASD. If there is any obstruction at the level of foramen ovale, it will be shown very well from the subxiphoid view. As we discussed earlier, most of the coronary sinus Ta Pvcs are unobstructed. They do not have any gradient along the pathway. Subxiphoid short axis view is the best view to delineate the entire dilated coronary sinus. It is important to document the unobstructed flow in the entire coronary sinus. The treatment of coronary sinus Ta Pvcs will be to surgically de-roof this entire coronary sinus so that the pulmonary venous blood that flows into the proximal coronary sinus directly enters through the unroofing into the left atrium. And then subsequently the coronary sinus ostia as well as the fossa ovalis ASD will be closed with a pericardial patch. On a posterior sweep, we see the dilated coronary sinus from the apical view. When we are visualizing the coronary sinus, we should not be able to see the complete opening of the mitral valve because the coronary sinus is at a plane which is posterior to the mitral valve. Once again, in this example of coronary sinus Ta Pvc, we again reconfirm the normal drainage of all the four pulmonary veins into the same confluence which ultimately drains into the coronary sinus. We can see that the upper pulmonary vein on both the right side and the left side take the blue color and the lower pulmonary veins take a red color. Even though most coronary sinus Ta Pvcs are unobstructed, some of them may have an associated very small left atrium, and these infants will have a restriction of blood flow from the right atrium into the left atrium. These patients may present with severe pulmonary arterial hypertension. We show such an example of a coronary sinus. In this subxifoid coronal view, we see the markedly dilated coronary sinus, which drains the pulmonary veins into the right atrium. When we interrogate the color flows, we see unobstructed pulmonary venous drainage into the coronary sinus and subsequently into the right atrium. We see that the inferior vena cava and hepatic veins to be congested. These are features of pulmonary arterial hypertension and congestive heart failure. You notice that the foramen ovale is adequate, however, the left atrium is very small. On an apical four-chamber view, we appreciate very well the small size of the left atrium. The right atrium and right ventricle are dilated. The right ventricular systolic contractility is very low. On parasternal long axis view, the small left atrium is seen between the aortic root anteriorly and the coronary sinus posteriorly. On the same parasternal view, if we make a rightward sweep and get the right ventricle in view, we appreciate that the right ventricle is markedly hypertrophied, trabeculated, and has poor systolic contractility due to severe pulmonary hypertension. We can see the coronary sinus, which is very dilated, draining into the right atrium immediately posterior to the tricuspid annulus. In this clinical situation, the reason for severe pulmonary arterial hypertension is due to the small size of the left atrium. Apical four-chamber view shows how small the left atrium is in comparison to the right atrium. The left atrium from the intraatrial septal level to the left atrial free wall is measuring only about 12 millimeters. We already stressed about the utility of pulmonary regurgitation jet as an indicator of the pulmonary arterial mean pressure. In this patient, the pulmonary regurgitation is shown by spectral Doppler, and the peak of pulmonary regurgitation is close to 42 millimeters of mercury, which gives a rough idea about the pulmonary arterial mean pressure. After seeing two examples of coronary sinus Ta Pvc, the first one was unobstructed, the second one was also unobstructed but was associated with a small left atrium that caused pulmonary hypertension. We move on to a third example of coronary sinus Ta Pvc where there is a significant obstruction from the confluence to the coronary sinus. From a subxifoid coronal view, we find a good sized confluence or common chamber at the upper end of the screen. However, as it enters into the dilated coronary sinus, there is a tight obstruction at the level of its junction into the coronary sinus. This results in pulmonary venous obstruction. In subxifoid short axis view, we are able to identify the site of the obstruction. The level of narrowing is at the point of junction of the common chamber into the coronary sinus. If we have to demonstrate it in the form of a cartoon, we find all the four pulmonary veins draining into a good sized common chamber or confluence. However, as it enters the coronary sinus, the entry point into the coronary sinus is tightly narrowed. On a spectral Doppler recording, we are able to appreciate the gradients at this level. We record a mean gradient of around 9 millimeters of mercury in this particular example of obstructed Ta Pvc. From the suprasternal view, we appreciate that the right upper and right lower pulmonary veins are well formed. The common chamber or confluence is also well formed. However, the point where the confluence joins the coronary sinus is significantly narrowed and shows a mosaic pattern. From the suprasternal view, we zoom into the confluence, which looks to be a very good chamber. However, the point where the confluence enters into the coronary sinus is narrowed. We have to remember that in coronary sinus Ta PVCs, the coronary sinus in the left posterior AV groove behind the mitral annulus is significantly dilated. We need to differentiate a dilated coronary sinus as a part of Ta PVC from a left superior vena cava which is draining into a coronary sinus. In the latter, the coronary sinus appears like a parallel track with the same lumen diameter. But in coronary sinus Ta PVC, the coronary sinus gradually widens proximally as the pulmonary veins enter. This is how you will see a coronary sinus Ta PVC from the apical 4-chamber view. The coronary sinus is dilated. The coronary sinus entry point into the right atrium is the narrowest portion of the coronary sinus, and proximally it keeps dilating as it receives the pulmonary vein. On a color Doppler mode, we are able to appreciate that the narrowest point of the coronary sinus is the place where the coronary sinus enters the right atrium, but proximally the coronary sinus is much larger. In the subsequent coronal view also, we are able to appreciate that the narrower portion of the coronary sinus is at the coronary sinus right atrial entry, and proximally the coronary sinus is much more dilated. Therefore, the rule in coronary sinus Ta PVC is progressive widening of the coronary sinus in its proximal course. On the contrary, in a left superior vena cava that is entering the coronary sinus, a benign entity, a simple systemic venous anomaly, the coronary sinus is more like a parallel track. The diameter of the coronary sinus is the same along the entire length of the coronary sinus. We will show both the examples side by side. On the left side of the screen, you see a coronary sinus Ta PVC. The coronary sinus is narrower in the place where it enters the right atrium, but proximally it widens out. Whereas on the right hand side, the screen shows a left superior vena cava draining into the coronary sinus without any abnormality of the pulmonary venous drainage. Here, the coronary sinus appears more like a parallel track and is uniform in diameter. We now move on to a new example of coronary sinus Ta PVC where the atrial septal defect is in the form of a tunnel. We are able to see the tunnel between the thick ledge-like septum secundum, and posteriorly the septum primum is appearing as a thin membrane. When the atrial septal defect takes the form of a tunnel, it may be obstructive sometimes. Color Doppler evaluation will show if there is any obstruction along this tunnel-like foramen way. Surgical repair of the coronary sinus will involve unroofing of the coronary sinus to achieve a non-restrictive communication between the coronary sinus and the left atrium, and then closing the coronary sinus ostium and the fossa ovalis ASD with a redundant pericardial patch so as to create more room for the left atrium. If the unroofing of the coronary sinus is not done completely, there will not be a non-restrictive flow from the coronary sinus into the left atrium. In this example, following closure of the coronary sinus Ta PVC, there is still a persistence of the gradient. You can see a dilated coronary sinus. The ostium that is connecting the coronary sinus into the left atrium, which actually has been the surgical unroofed area, is grossly inadequate. So this results in a persistence of pulmonary venous obstruction. Whenever the unroofing of the coronary sinus is not completely done, we can see that the partial roof of the coronary sinus protrudes as a ledge in the left atrium, thereby causing a pulmonary venous anastomotic obstruction. From the apical 4-chamber view, we are able to appreciate the turbulent flow entering into the left atrium due to the partial unroofing of the coronary sinus. In these cases, if the atrial septal pericardial patch had been more redundant, the level of pulmonary venous obstruction will not be severe. In this patient, the pericardial patch also has fibrosed and has become shorter and rigid, thereby making the pulmonary venous obstruction more obvious. Let us now move on to the right atrial type of Ta Pvc. On a subxiphoid coronal view, we are able to appreciate the pulmonary veins draining onto the posterior wall of the right atrium. We can see posterior to the right atrium, the right pulmonary veins and the left pulmonary veins converging towards the posterior wall of the right atrium. After the blood enters the right atrium, it courses into the left atrium through the small fossa ovalis ASD, which is shown by a blue color with the second arrow. On a subxiphoid short axis view, we are able to appreciate the superior and the inferior vena cava entering the right atrium, and on the posterior wall of the right atrium, we see the common chamber from the pulmonary veins entering directly on its posterior wall. The flow of blood from the common chamber onto the posterior wall of the right atrium is confirmed by color Doppler, which is shown by a red color. What is shown below the red as blue is the flow from the right atrium into the left atrium. The best view to see all the 4 pulmonary veins will be the subxiphoid coronal sweep, where we can simultaneously see the right and the left pulmonary veins draining into the common chamber and then into the right atrium. On an apical 4-chamber view, we appreciate the common chamber draining onto the posterior wall of the right atrium. We can see the right atrial and right ventricle dilatation in the smaller left atrium and the smaller left ventricle. Surgical repair of this type of Ta Pvc will involve an atrial septal baffling, thereby rerouting the pulmonary veins towards the left atrium and the mitral valve orifice. This echocardiogram shows the subxiphoid short axis view after such a surgical repair. We are able to see the thin echogenic pericardial patch directing all the pulmonary venous blood towards the left atrium posteriorly. A subxiphoid coronal view seen after the surgical repair. We can see the thin bowing pericardial patch, and all the pulmonary veins are baffled through this pericardial patch back into the left atrium. A color Doppler confirms the unobstructed flow from the pulmonary venous confluence towards the left atrium. The right atrial form of Ta Pvc is considered to be caused by a malalignment of the septum primum. The pulmonary veins drain on the posterior wall of the atrium. However, due to a leftward shift of the septum primum, the drainage of the pulmonary veins are towards the right atrium rather than towards the left atrium. This subxiphoid coronal view shows the drainage of both the right and the left pulmonary veins into the posterior wall of the dilated right atrium. Once again, we wish to reiterate that the descending thoracic aorta has to be identified between the right-sided pulmonary veins and the left-sided pulmonary veins. The descending thoracic aorta here is seen as a circular structure, most posterior structure. Color Doppler shows drainage of both the right and the left pulmonary veins into the posterior wall of the right atrium. In this color compare mode, we are able to appreciate both the right pulmonary veins and the left pulmonary veins coming from either side of the descending thoracic aorta and draining onto the posterior wall of the right atrium without any obstruction. When we sweep anteriorly on the same subxiphoid coronal view, we see the flow of blood from the right atrium into the left atrium through a large secundum atrial septal defect. On an apical four-chamber view, we are able to appreciate the right pulmonary veins prominently entering into the right atrium. We can also see the left pulmonary veins as a small thin red channel, and that is also draining into the posterior wall of the right atrium. We can appreciate how much the septum primum is malaligned to create a small left atrium and a large right atrium. The descending thoracic aorta is seen between the right pulmonary veins and the left pulmonary veins. If we have to demonstrate it as a cartoon, we see there is a malalignment of the atrial septum. The pulmonary veins which drain onto the posterior wall of the atria are now draining into the right atrium because of this septal malalignment. In this modified parasternal view, the posterior wall of the right atrium receives both the right and the left pulmonary veins, and we are able to appreciate the inferior vena cava drainage onto the postero-inferior wall of the right atrium also. All the three are shown by arrows. We can also appreciate that the descending thoracic aorta is seen between the right and the left pulmonary veins. We will show another example of a right atrial type of Ta Pvc in a situs inversus dextrocardia mirror image situation. The basic pathology remains as the deviation of primum septum towards the morphological left atrium, thereby resulting in the drainage of all the pulmonary veins towards the morphological right atrium. A subxiphoid coronal view in this mirror image situs inversus dextrocardia. So what is seen on the right side of the screen is the morphological right atrium, and what is seen on the left side of the screen is the small morphological left atrium. In the same subxiphoid coronal view, as we sweep anteriorly, we are able to appreciate the superior vena cava entering the morphological right atrium. The superior vena cava is actually on the left side due to the mirror imagery. When we sweep posteriorly, we are able to appreciate both the pulmonary veins entering into the same morphological right atrium. A still frame showing drainage of both the right and the left pulmonary veins into the morphological right atrium posteriorly. On a right apical four-chamber view, we see the mirror imagery. The morphological right atrium and right ventricle are seen on the left side. The morphological right atrium and right ventricle are significantly dilated, and the left atrium and left ventricle are much smaller. We can appreciate all the pulmonary veins converging onto the morphological right atrium on its posterior wall in this apical view. The most important point to remember about the right atrial Ta Pvcs are that it is caused by a malalignment of the septum towards the morphological left atrium. In this apical four-chamber view, it is nicely demonstrated. In this patient with situs inversus dextrocardia mirror imagery, we can appreciate the aorta and pulmonary artery relationship are also inversely related to the normal. On a suprasternal view, we find that both the innominate veins are converging towards the left-sided superior vena cava that drains into the left-sided morphological right atrium, which is a classical feature of mirror imagery. Whenever the primum septum is malaligned markedly towards the left side, all the four pulmonary veins will drain onto the posterior wall of right atrium. However, if the septal malalignment is only minimal, it will result only in the right pulmonary veins draining anomalously into the right atrium, and the left pulmonary veins will drain normally into the left atrium itself. It depends on the extent of the septum primum malalignment to dictate whether all the four pulmonary veins are going to be draining into the right atrium or only a partial drainage. In this example, On a subsified coronal view, we find that the atrial septum is minimally malaligned towards the left side. This has resulted in the right pulmonary veins draining onto the posterior wall of the right atrium as shown by the arrow. On a color flow interrogation, we can appreciate the right pulmonary veins draining onto the posterior wall of the right atrium on the other side of the atrial septum. On a superior sweep, we can appreciate the right upper pulmonary vein also draining into the right atrium. So this constitutes a hemianomalous pulmonary venous connection of the right-sided pulmonary veins towards the right atrium. On the subsified coronal view, we can appreciate the color flow from the right upper pulmonary vein into the right atrium. In the apical four-chamber view, the extent of malalignment of the atrial septum is only very minimal. So this results in drainage of the right pulmonary veins alone into the right atrium, whereas the left pulmonary veins normally drain into the left atrium. We can appreciate the flows from the right pulmonary veins onto the posterior wall of the right atrium on the right side of the atrial septum. On a three-dimensional echocardiogram, we can appreciate the atrial septum very well. The right atrium and the left atrium are seen on either side of the atrial septum. We can see the superior vena cava entering into the right atrium superiorly, and on the posterior wall of the right atrium, the right pulmonary veins are seen entering. The double arrows show the minimal malalignment of the atrial septum towards the left side. We have so far seen a large number of examples of supracardiac Ta Pvcs and intracardiac Ta Pvcs. In all these instances, we were able to appreciate the pulmonary veins individually draining into the common chamber, and then from the common chamber track the flow of the blood into the right atrium. However, all patients with cardiac and supracardiac Ta Pvcs cannot be delineated by echo alone. In this example, from the suprasternal view, we appreciate all the four pulmonary veins converging into a common chamber. And from the common chamber, there is a vertical vein that courses downwards. When the color sector is taken out, we appreciate that the pulmonary venous confluence is draining through a large vein that courses to the left of the confluence and then subsequently courses inferiorly. This gave a visual impression as if it is an infracardiac Ta Pvc. However, when we tried to look at from subsified view, we found that there was an ascending vein that coursed all the way up and then drained onto the posterior wall of the right superior vena cava like an azygos vein. If we have to represent in a cartoon what we saw, we were able to appreciate the pulmonary veins converging onto a confluence. The confluence was draining off a channel which moved towards the left of the common chamber, then coursed inferiorly, and then it took a superior turn and drained onto the posterior wall of the right superior vena cava. Whenever there are too much of uncertainties, it's better to resort to angiogram, either a CT pulmonary angiogram or a conventional catheter angiogram. Here, a catheter is introduced into the pulmonary artery and a pulmonary arterial angiogram has been done. And when we look at the levo phase, the pulmonary veins fill a common chamber. The common chamber drains through a vein that initially coursed inferiorly towards the dome of the diaphragm. However, at the right paravertebral gutter, it turned superiorly and ascended up as an ascending right vertical vein, and the pulmonary venous flow subsequently enters the right superior vena cava. When we are making the pulmonary arterial injection, due to severe pulmonary arterial hypertension and persistence of a small ductus arteriosus, we are able to see a small puff of the contrast from the pulmonary artery through the ductus into the descending thoracic aorta in the initial frames. After this long discussion on supracardiac and intracardiac types of Ta Pvcs, let us move on to infradiaphragmatic Ta Pvc. Infradiaphragmatic Ta Pvc is appreciated best on subxified view. On the subxified view, after we visualize the flow in the abdominal portion of the aorta, anterior to the aorta, there will be another parallel channel that will show a red color. But unlike the aorta, it will not be phasic in systole, it will be continuous throughout systole and diastole. If we do a pulse Doppler interrogation of these two blood vessels, the aorta will show a phasic systolic signal, whereas the pulmonary veins will show a low velocity continuous signal. The vertical vein in an infracardiac Ta Pvc often penetrates the diaphragm through the esophageal hiatus. So whenever the child cries and increases the intra-abdominal pressure, the diaphragmatic orifice of the vertical vein gets further narrowed and the child goes into a state of pallor, bradycardia, lifelessness, and this can even be fatal. From the suprasternal view, we can appreciate the formation of the common chamber. However, the common chamber drains inferiorly towards the diaphragm, and we can see a left vertical vein that courses inferiorly, taking the blue color. The confluence is best appreciated from the suprasternal view, located below the right pulmonary artery. If we draw a cartoon of this infracardiac Ta Pvc, all the four pulmonary veins converge to the common chamber. It descends down as a vertical vein, enters through the esophageal hiatus and courses down commonly towards the portal vein and enters into the portal vein. Here, the blood flow has to traverse the entire liver parenchyma to ultimately enter into the hepatic veins. If the newborns have a persistence of the patency of ductus venosus, the flow of the pulmonary veins into the portal vein will immediately be decompressed through the ductus venosus into the hepatic veins, thereby facilitating the flow into the right atrium. However, as the ductus venosus closes, the pulmonary venous flow has to go obligatorily through the liver parenchyma to ultimately enter the hepatic veins and the inferior vena cava. The demonstration of the vertical vein on subxiphoid long axis view is the classical hallmark in the diagnosis of infracardiac Ta Pvcs. Surgical repair of infracardiac Ta Pvc is exactly similar to the repair of supracardiac Ta Pvc. We have to anastomose the common chamber onto the posterior wall of the left atrium. Usually the anastomosis will be wide open and there will be unobstructed flows from the common chamber into the left atrium. However, if there is a cicatricial narrowing and fibrosis of the anastomotic orifice, this results in an anastomotic gradient between the common chamber and the left atrium. On an apical four-chamber view, we are able to appreciate the narrow jet from the common chamber into the left atrium due to anastomotic narrowing. We need to identify whether the obstruction is due to anastomotic narrowing or due to diffusely small size of the confluence or common chamber. In this particular example, we appreciate that the common chamber is well formed. In fact, the common chamber is dilated and distended, and there is a tight anastomotic obstruction. The entire common chamber, the left atrium, the anastomosis, and the narrow region of the anastomotic junction is well visualized in this apical view. The still frame shows how narrow is the anastomotic obstruction and how much of inadequacy to the return of pulmonary veins will be affected by this small orifice. On a spectral Doppler evaluation, we find that there is a mean gradient of close to 16 millimeters of mercury across this anastomotic obstruction. Most patients with intracardiac Ta Pvc will be very sick due to very severe pulmonary arterial hypertension. The second example of intracardiac Ta Pvc shows a dilated right atrium and right ventricle with markedly impaired right ventricular systolic function, an indicator of the severity of pulmonary arterial hypertension. On a subxiphoid short axis view, we can appreciate the dilated right ventricle. The interventricular septum is bowing into the left ventricle, and there is tricuspid regurgitation and pulmonary regurgitation indicative of pulmonary arterial hypertension. The interventricular septum, when it is seen moving into the left ventricle, is a very clear-cut indication of the right ventricular systolic pressure being higher than the left ventricular systolic pressure, thereby indicating suprasystemic PA pressures. On a subxiphoid view, we visualize the vertical vein entering the diaphragm at the esophageal hiatus. You notice that the flow in the vertical vein is laminar up to the point where it penetrates the diaphragm. However, at the diaphragmatic entry point, it becomes very turbulent. This is an indicator of an obstruction of the pathway at the level of the diaphragm. This picture, again from the subxiphoid view, shows the course of the vertical vein anterior to the thoracic aorta and posterior to the heart. This shows the intrathoracic portion of the vertical vein. The last type of Ta Pvc will be the mixed Ta Pvc. Here, the pulmonary veins do not have a single focus of drainage. Some of them may be intracardiac, some of them may be supracardiac, and there will be a mixed pattern of drainage. In this example, we find that there is a pulmonary venous drainage through the dilated coronary sinus into the right atrium. However, if we carefully look at the heart, we also find that there is a dilated right superior vena cava. This indicates that all the pulmonary veins may not be draining into the coronary sinus, and there may be some pulmonary vein which will have an independent drainage towards the right superior vena cava. You can also appreciate the large atrial septal defect and the laminar blue color flow from the right atrium into the left atrium. On a parasternal short axis view, we are able to appreciate the right upper, right lower, and the left lower pulmonary vein entering onto the coronary sinus. However, the left upper pulmonary vein is not visualized. This left upper pulmonary vein drains as a left vertical vein onto the left innominate vein and subsequently towards the right superior vena cava. So in this patient, the right upper, right lower and the left lower pulmonary veins have drained into the coronary sinus, whereas the left upper pulmonary vein is draining through a left vertical vein into the left innominate vein. This is the feature of mixed Ta Pvc. The large left vertical vein is draining the left upper pulmonary vein. So far we had seen different types of anomalous pulmonary venous drainage, starting from supracardiac Ta Pvcs, moving on to intracardiac Ta Pvcs, subsequently infradiaphragmatic Ta Pvcs, and last mixed types of Ta Pvc. We move on to the second group of pulmonary venous abnormalities, namely the cor triatriatum. Cor triatriatum sinister, or in other words called as divided left atrium, is caused by an obstructive membrane within the left atrium, separating the mitral orifice and the left atrial appendage anteriorly and the pulmonary venous orifices posteriorly. If this membrane is significantly obstructive, this produces pulmonary venous hypertension. Some of these patients may have an associated atrial septal defect, and some of these patients may have an associated anomalous pulmonary venous drainage as well. This is an apical view of a patient. You can see an oblique partitioning membrane in the left atrium which divides the left atrium into two chambers. There is a small orifice in the membrane at the superior end of the membrane, and that causes a turbulent flow from the upper chamber into the lower chamber of the left atrium. On a still frame, we can appreciate the oblique slanting membrane that partitions the left atrium. This condition is called as the cardiac sinister, or partitioned left atrium, or divided left atrium. The characteristic features are that the upper chamber will always be receiving all the pulmonary veins, and the lower chamber will be connected to the left atrial appendage and to the mitral valve orifice. The apical view clearly shows the partitioning of the left atrium into two chambers. The membrane is very oblique, and what is shown by the green arrow is a small orifice in the membrane through which the pulmonary veins are able to find their blood flowing into the lower chamber of the left atrium. The turbulent flow through the small orifice in the membrane is shown by the green arrow. In a parasternal short axis view, the arrows show the entry of the left upper and the left lower pulmonary vein onto the upper chamber of the cardiac atrium. The right lower pulmonary vein is also shown. The upper chamber of the left atrium is demarcated as LA. You can see that there is a membrane that partitions the left atrium, and anterior and inferiorly the lower chamber is related to the left atrial appendage. In a moving frame of the parasternal short axis view, we are able to appreciate the obstructive membrane very clearly. The left atrial appendage is always seen in relation to the lower chamber of the cardiac atrium. Through the small orifice in the membrane, there is a significant turbulent flow from the upper chamber of the left atrium into the lower chamber of the left atrium. The small orifice in the obstructive membrane in left atrium is shown by this arrow, and a turbulent flow is seen through that. A spectral Doppler evaluation shows that there is a substantial gradient. There is a 13 mm mean gradient from the upper chamber to the lower chamber, constituting a significant pulmonary venous obstruction. To reinforce the understanding of cardiac sinister, we wish to show you another example of a complete cardiac atrium, a completely partitioned left atrium, a completely divided left atrium. Contrary to the previous example that we showed, where the orifice of the membrane was close to the lateral wall of the left atrium, here the orifice in the membrane is close to the intraatrial septum. You can see the turbulent flow from the upper chamber into the lower chamber through that small orifice in the obstructive membrane. Spectral Doppler evaluation shows that the obstruction is even more severe. There is a mean gradient of 18 mm of mercury. On a subxiphoid coronal view, we are able to see the partitioning of the left atrium very clearly. The large obstructive membrane is seen coursing entirely across the left atrium. Color Doppler shows that the orifice in the obstructive membrane is very close to the intraatrial septum, and the entire pulmonary venous return is coursing through this small orifice from the upper chamber into the lower chamber of the left atrium. On a parasternal long axis view also, this membrane is very clearly visible. The upper chamber of the left atrium is large and dilated due to higher pressure, and the lower chamber is in close relation to the mitral valve orifice. Sometimes the cartridge atrium can be partial. This means a partially divided left atrium or a partially partitioned left atrium. In this condition, the right or left pulmonary venous drainage alone may be separated from the main left atrial cavity by an obstructive membrane. This is an example of a partial cartridge atrium. This apical four-chamber view shows turbulent flows into the left atrium in the region of the right pulmonary venous drainage alone. On an apical four-chamber view, we are able to faintly visualize a thin obstructive membrane in the region of the right pulmonary veins entry point into the left atrium. Color Doppler indicates that there is a substantial obstruction of the drainage of right pulmonary veins into the left atrium caused by this partial core membrane. The gradients across this partial core membrane is quite substantial. It is exceeding 2 meters per second, which means the mean gradients are in the range of 20 millimeters of mercury. A transesophageal echocardiogram done on the same patient shows the partial cartridge atrium membrane in the left atrium very clearly. The right pulmonary veins enter the proximal portion of the left atrium and then is obstructed by a thin membrane. A small orifice allows the blood flow from the right pulmonary venous common chamber into the remaining portions of the left atrium. When we suppress the color sector, we are able to clearly see that obstructive membrane. On the left of the screen is the place where the right pulmonary veins drain. On the right of the screen is the remaining portion of the left atrium. We can see a small orifice between this upper chamber and the lower chamber. This membrane was posterior to the intraatrial septum. After this obstructive membrane causing a partial cartridge atrium was avulsed by a transcatheter approach, the flows in the left atrium totally normalizes. The left pulmonary venous drainage into the left atrium was normal even before. So this partial cartridge atrium causes unilateral pulmonary venous hypertension. Sometimes cartridge atrium sinister or partitioned left atrium may coexist with an anomalous pulmonary venous drainage. Subxifoid coronal view of this patient shows a long obstructive membrane across the left atrium, dividing it into two parts. Apical view shows this obstructive membrane even more clearly. Whenever there is a lack of intraatrial communication, there will not be much of dilatation of the right atrium and right ventricle. However, in this patient, there is some enlargement of the right atrium and right ventricle. This gives a clue that the cartridge atrium may be associated with some form of anomalous pulmonary venous drainage resulting in a left-right shunt. The pulmonary venous flows entering the upper chamber is seen very well. There is a small turbulent flow seen through the membrane closer to the intraatrial septum. This indicates the site of entry from the upper chamber into the lower chamber of the cartridge atrium. When the suprasternal view is seen, we can find a large left vertical vein in the same patient. This indicates that the cartridge atrium is partially getting decompressed through this left vertical vein to the left innominate vein, subsequently to the right superior vena cava and the right atrium. Part of the pulmonary venous flows go through the small orifice in the obstructive membrane of carotid atrium into the lower chamber of the left atrium and thereby gaining access into the mitral valve. Carotid atrium means divided atrium or partitioned atrium. In carotid atrium sinister, there is one right atrial cavity and two parts of the left atrial cavity. There is an entity described as carotid atrium dexter, which means divided right atrium or partitioned right atrium. This happens due to an abnormally long persistent Eustachian valve of the inferior vena cava that forms a thin Chiari network, and this membrane gets attached to some portion of the right atrium, thereby showing an appearance of partitioned right atrium. We will now move on to the last type of pulmonary venous abnormality, namely the pulmonary vein stenosis or pulmonary vein atresia. The pulmonary venous stenosis can involve single pulmonary veins or involve multiple pulmonary veins. Sometimes it can diffusely inform the entire pulmonary venous tree, called as pulmonary veno-occlusive disease. This is an example of a single right lower pulmonary vein stenosis. All the other pulmonary veins were normal. The right lower pulmonary vein alone was getting substantially narrowed as it entered the left atrium. When we do a Doppler interrogation on the single pulmonary venous stenosis, sometimes there may not be very high gradients. This is due to redistribution of the pulmonary blood flow to the other healthier segments of the other lung. On a parasternal short axis view showing both the pulmonary arteries, we interrogate the blood flow in the right and the left pulmonary artery. The left pulmonary artery is having very brisk flows. We don't see a good color flow into the right pulmonary artery at all. This is indicative of a redistribution of the blood flows more towards the left lung and reducing the flow into the right lung. This sort of compensatory pulmonary arteriolar spasm is commonly seen in unilateral pulmonary venous occlusions. When we do a selective pulse wave Doppler interrogation of the right and left pulmonary artery, we will be able to appreciate the redistribution of the pulmonary blood flow very clearly. In the right pulmonary artery, there is a very low velocity flow and the peak velocity is only 0.4 meter per second. However, due to the compensatory left lung hyperperfusion, the left pulmonary artery Doppler velocity is more than 1.1 meter per second. This redistribution of the pulmonary blood flow to one or the other lung can only be appreciated if we do a selective pulse wave Doppler on the proximal pulmonary artery flows in these patients. In this second example, we see a left pulmonary vein stenosis. There is a turbulent flow from the left pulmonary veins, whereas the right pulmonary venous drainage is normal. The spectral Doppler gradients across this left pulmonary vein shows a mean gradient of around 9 millimeters of mercury. The patients who present with these pulmonary vein stenosis as an isolated entity do not have a great longevity. Whether it is with medical follow-up or with surgical management or with transcatheter management, the pulmonary veins continue to cause a severe venous occlusion and these patients do not do clinically very well. This is an example of stenting of the left pulmonary veins in a patient who had a tight left pulmonary vein stenosis. Sometimes this sort of treatment is resorted to when the patients are ventilator dependent and we are unable to extubate these patients. However, they never give a long-term palliation. After 2 months of stent deployment of the left pulmonary veins, there is a recurrence of stenosis and you can see a turbulent flow through the stent. To summarize, in this module we saw different types of pulmonary venous abnormalities. We started off with total anomalous pulmonary venous drainage. We went through the different types of supracardiac, intracardiac and infracardiac Ta Pvcs. We also saw mixed Ta Pvcs. Then we went on to see some examples of partial anomalous pulmonary venous drainage. Then we saw some examples of total carotid atrium and partial carotid atrium. Carotid atrium with associated pulmonary venous drainage anomalies, single and multiple pulmonary vein stenosis.